I think that's unmuted everyone now.
Hi. Maybe we take that away. Can you guys hear me? Can you hear me? Okay now? Yeah. Okay. Can you hear me still? Yes. All right. Okay. Was that in the beginning? Okay. Again, I'm one of the faculty fellows. Today I'd like to talk about hypernatremia in the ICU. I will try to make it as relevant as possible. Thank you to Dr. Udeman, who was being my mentor for this presentation. So we'll start with a case. So we have an 80-year-old woman, septic shock, pneumonia, recovering well, actually on day 6. Yes, I am near a mic. Like this. Okay. Okay. Are you able to hear me? Okay. We'll hold the phone. Okay, so this patient was actually on day 6. She was noted to have hypernatremia around 58. She had stable vital signs and normal blood glucose with normal renal function. And her charts indicated she has 6 liters cumulative fluid gain. She weighs 58 kilo and she was 57 on admission. What is the likely cause of this patient's hypernatremia? And I actually clicked it already. So the answer is limited free water intake, and hopefully by the end of this presentation, I will have a good understanding of why. Relax. Okay. Okay. Okay, we're gonna have to pause for a minute here. Hello? Sure. Can you hear me? We have an external mic now. Can you hear me? Okay. Perfect, thank you. Okay, so overview of hypernatremia. It is defined as any sodium level greater than 145 millimole per liter, and is always associated with hyperosmolality or hyperosmolality. Okay, much better. Awesome. Okay, it is a disorder of the relationship between water and sodium. And majority of the time, it is stemmed down to a deficit of free water, more common than the gain of sodium. Okay, so just a quick overview about review about total body water. So about 60% of our body is made of water. 2/3 of that stay intracellularly, and 1/3 of that stay extracellular. And in that extracellular space, there's about 3/4 stays in the interstitial, and only 1/4 go to the stays in the plasma or in the vessels. Here we have the different compartments, electrolytes in different compartments. The blood plasma, which is in red, we can see that the sodium is quite high, and the chloride is high, as well as the protein here, and the bicarb. As far as for the interstitial fluid, which is blue, and it is reflecting the profile of electrolyte profile of the plasma, and you know, it's kind of in hand with the extracellular compartments. For the intracellular fluids, as we can see here, the potassium is a lot higher and the sodium is a lot less, and phos is higher as well as protein is higher, and this is why sometimes we have case of tummolysis, or we have case of rhabdo, we have hyperkalemia and hyperphos happening. And the reason, or one of the big reasons for there's a big difference between the sodium and the potassium intracellular compared to extracellular are the ATP, the sodium potassium ATPase pump, which maintain the gradient between the two. Here are just the different various of gastrointestinal fluids, nasogastric drainage, diarrhea, ileostomy to sweats. As we can see, look at the sodium here. Most of them have lower sodium contents than the blood. So as we lose any of these fluids, we are actually losing more free water than salts. And the Dr. Edelman in the 1950s came up with the equation where he said, since the intracellular potassium is nearly the same as extracellular sodium, as we saw it 2 slides earlier, it is postulated that the total sodium and the total potassium over the total body water will give us a estimate of the serum sodium. And this is because sodium and potassium are exchangeable between the intracellular and the extracellular space. And it helps, this is done by the, again, the ATP, the sodium potassium ATPase channel. And it helps maintain the neutral osmotic gradients. So, for example here, if we give someone sodium, the sodium will preferably try to stay in figure A here. The sodium would preferably stay extracellularly, and which will increase the osmolality, then will absorb some of the water from the intracellular space. That's why we see if we look at the second figure here, the sodium, the water contents is a bit higher than 18 liters to 18.4. And some of the potassium will automatically go into intracellularly to maintain the neutral osmotic gradients. So you can see the potassium 4.1, 4.2 came down to 4.1 here. So hence we use both potassium and sodium to estimate the serum sodium. You can't talk about hypernatremia without osmosis and tonicity concept, where osmosis happens to describe the water movement between the osmotic gradients. It moves toward the higher osmotic gradients. And on figure A here, we can see in this flask, the water is separated by a semi-permeable membrane. And there are extra solutes in there. And this solutes cannot cross freely. And if we leave it for some time, it will come over the water, will do osmosis and seep over to the area with the side with higher solutes. Osmolality describes the concentration within a solute. It's just a number for us to look at to help determine how high the osmotic force can be. Tonicity, on the other hand, is a capacity or capability of a solution to change the cell volume using osmosis. Now, how we describe it is we put a cell into a solution and it stays the same. The cell stays the same size, then it's considered isotonic solution. But if we put the cell in a solution, then it swells up, where the osmotic force inside of the cell absorb water from the surrounding, then this the solution is considered a hypotonic solution. Same thing with and vice versa for hypertonic, where the cell will shrink because the solution is taking water from the cell. And hyperosmolarity is not always associated with hypertonicity. It is solute dependent. And so sodium and glucose, they need transporters, so they can't cross the cell membrane freely. Just like in this previous picture here in B, the solutes inside this red blood cell does not cross freely, so it can lead to tonicity. And it can lead to the cell volume changes. So this is why we worry about cerebral edema more in hypernatremia correcting rapidly, or in hyperglycemia case when we correct them rapidly as well. In the case of, let's say, for urea or ethanol, these solids crosses pretty freely. So it raises the osmolarity as a whole, but it does not cause tonicity change because, again, the solute just seep in between, in and out of the cells, and the cell doesn't change its size. And another term is dehydration versus hypovolemia. We tend to use this interchangeably, but for dehydration, it's mainly the loss of water. And for hypovolemia, it is loss of both water and solids. And it's vice versa for gaining case. Our body maintain a sodium level by, mainly by just taking in water, just thirst. And the average fluid requirement is about 30 cc per kg. Sounds familiar, right? The minimum of 15 cc per day. And so we don't take enough water through, by mouth or any other measure, parenteral, the osmolarity will increase. As little as 1% can trigger the hypothalamus to release ADH and also increase the feeling of thirst. And we trigger to drink water, and then the osmo will come back. Same thing with in the opposite for large water intake. That will cause a falls in serum osmol and shut off ADH, and then we just become water diuresis, and the sodium will come back to normal. So this is how we our body regulated water and sodium. Here's a closer, more graphic presentation as the osmolar receptor will, perceive a change in osmolality and cause ADH release from the hypothalamus, or ADH trigger to release from the posterior pituitary gland. And then also a thirst mechanism here. ADH will come down to the kidneys and act on this collecting ducts and cause an increase in absorption of free water. And ADH does also cause a vasoconstriction in the V1 receptor. So whenever there's a hypovolemic picture, baroreceptor from the aortic arch will also trigger the hypothalamus to release it. And when there's hypovolemia, also the kidney will sense it and trigger a RAS system to activate and cause angiotensin II to release of the ADH. So hypernatremia in the ICU. The prevalence is, so they describe it actually rare when a patient is hospitalized, up to 1%. And if it happens, it mainly happens in the geriatric or pediatric population. And for critical ill patients, it can go up to 26% in the MICU and 10% in the surgical ICU. The short-term mortality of approximately 40 to 60%. And this is could be an association. And for sodium greater than 150. Sodium greater than 145 can confers a mortality of greater than 20%. Here's a study from 1999. It's a single study back, and they were trying to look at hypernatremia. Is it a good indicator for cardiac care? And they took about 400 patients. They found 9% has hypernatremia on admission. The definition of hypernatremia was 150 or above. And about 6% developed hypernatremia during the ICU course. And down here, at the end, they found that there was higher mortality in the group that acquired hypernatremia during their hospitalization compared to the group that got it on admissions. And they said this could be potentially used as an indicator for cardiac care in the ICU. It's another big study, 20 years later, roughly. Retrospective, about 20,000 people, they compare between community acquired versus hospital acquired. And their cutoff was 142 for hypernatremia. And this keeps flying the graph. Just they spot a bunch of hypernatremia sodium values compared to the mortality, and they found that 140 was the safest zone to be. Hence, they came up with number 142 for their study. And we see here the higher the hypernatremia, the higher probability of in-hospital mortality. They further subgroup these patients into with their comorbidities in the hypernatremia group, and they found that patient with heart failure, myocardial infarction, and COPD, and patient with high Charson comorbidity index or with CKD at baseline has higher hospital mortality, prolonged length of stay, as well as prolonged long or short-term care facility. Sepsis was not associated with it. Down here we have a list of studies that were done over the years. As we can see, most of them are retrospective, or all of them were retrospective. They use 145 as cutoff, or either 145 or 150. Large population in the thousands, and in mixed ICU or in surgical or MICU. And over the next column, we can see the incidence of ICU acquired. It can go up to 26% here. And the length of stay, compare between a hypernatremia and a non-hypernatremic group, is higher, as well as the mortality here. What about hypernatremia in the traumatic brain injury patients? Here's the single retrospective study of about 450 neurological admissions, ICU admissions. They found about 18% mortality rates in this 450 patients, and about 228 of them have hospital ICU acquired hypernatremia. And in this group, 36% mortality they found that was in the hypernatremic. And so they conclude that after they adjusted for the comorbidities, they found that they conclude that the hypernatremia is a independent risk factor for mortality in patient with TBI. And down here, figure A, if we look at the third column here, sodium greater than 155 has significantly higher day of mechanical ventilation and length of stay, and as well as lower GOS score, or Glasgow Outcome Scale. Down here, B is multivariable binary logistic regressions. And they conclude that we can use the GCS score as well as serum sodium peak for this study is 147 to be an indicator of mortality. We can see here those are the two factors that are significantly statistically significant. And from this same study, they graphed a receiving operating characteristic curve, and based on the correlation between the peak sodium 147 and mortality in the neurological ICU patient. And they found that patient 84% of the time, patient has higher mortality if they have a sodium peak above this number. The sensitivity of this was 79, and the specificity was 74%. So, summary of what we found. So all the prior studies were retrospective. Hypernatremia, after being adjusted for the known risk factors, is concluded to be an independent risk factor. However, there are other potential unknown confounders that we don't know, unknown, that we didn't take into account. Hypernatremia is associated with hyperosmolality states, and this is real. It is a known effect that it can cause adverse effects on the physiological function of cells. And the mortality rate correlates directly with the severity of the hypernatremia. So case 2, we have a 58-year-old woman with post-operative ileus going on NG tube suction. She's obtunded. She has diminished skin turgor and mild orthostatic hypertension. Great vital signs, sodium at 158, K of 4, good renal function, and weight of 63. Which of the following choices will likely to help correct patient's serum sodium to 148 over 24 hours? A, is it normal saline at 125, B, LR at 150, C, half normal at 200, D, D5 at 125, or E, still water. So automatically E is out of picture because we don't give E. So any taker? Yes, D. D is the correct answer. And we'll go over the calculation. So we'll go into more the calculation further, but just the shorthand is the total body water deficit, TBWD. We take the delta, meaning how much we want to change, and we subtract that from the original of sodium. So if in this case we want to change it by 10, and so we subtract it from 158, so that gives you 148. So the delta over the target, and multiply that by the total body water, which is for women is multiplied by 0.5, and for men is multiplied by 1.6. So this gives us 2100. And for the insensible loss here, it's about something we don't calculate often, something we can forget sometimes. And even the calculator on MetCal does not necessarily take this into account. But the it's about 15 cc or 14 to 15 cc per kg a day. So this patient has a 60 kilo weight, and she loses about a liter a day. This is mainly through skin and through pulmonary, respiratory. So the total water deficit is about 3 liters, and we take that divided by 24 hours, we get 125. Now, if we want to use D5 half normal saline, then we can, since the half normal saline there's half water in there, we can double the rates, and it would give us the similar, not as efficient as this. Okay, so the pathophysiology, so mainly two scenario, majority of the time is two scenario, and it's either sodium gain or water loss. And sodium gain is, you can either gain it from hypertonic solution, resuscitations, high sodium, like a lot of salt taps given to the patients. And it ends there. It's just like, it's not the major cause of hypernatremia. It is the water loss that we usually focus on. And the water loss, it could be from not taking enough in, or from losing from the kidney, or losing from not the kidney. And here they want to look at the electrolyte free water clearance. I won't go over that, but just basically when the body has a high osmolality state, the response will be high ADH coming down to the kidney and get the kidney to absorb as much water as possible. So that's the normal response. And then the urine will be, the osmolality of the urine will be high as well. So looking at the urine osmol, you can use it as a poor man's surrogate of the ADH states. Let's just say over on the right side here, the extra renal loss. So if we look at hypernatremia and there's high urine osmol, then that means the kidney is doing what it's supposed to. Then it's mainly it's extra renal loss, and that could be from having too much fever, having too much diarrhea, or nasogastric suction, and those are majority of the time those are the causes. And if we look at the urine osmol, and it's low in the case of hypernatremia, it's likely there's something wrong with the kidney. Regardless of, it can be like osmotic diuresis from hypoglycemia, or it can be from azotemia, like VUN of like 150 in kidney failure patients, acute. And for loop diuretics, we can lose free water that way, and renal insufficiency when they can't respond to the ADH effects. Diabetes insipidus is another potential cause when there's not enough ADH release. It's from the central, or there's something blocking the receptor in the kidney, like lithium. And here's another study, a retrospective study. of about 45 patients, and acquired hypernatremia in ICU. And they found that the top 5 causes are here: polyuria, acute renal failure, hypertonic solution, fever, or diarrhea. And 4 out of 5 of these causes has to do with water loss. Only hypertonic has to do with sodium gain. So the cells respond to hypernatremia. So here's the intracellular, interstitial, and the plasma. Is hypernatremia acutely happen because you're not drinking enough water. And the plasma and the interstitial will try to take water in to equilibrate it, to bring down the osmolality. Then the cell itself will try to compensate this. Short term, in hours, it can absorb more or open the channel for more sodium and potassium to come into, for more potassium and chloride to come into the cells to help with the osmotic gradients and help the cell absorb back some of these water. Then over the next couple of days, the cell will alter its cellular function to retain more osmolytes like mannitol or taurine to help increase its osmotic gradient intracellularly and sucks back some of the water and it re-expands. So that's generally what the cell does. What our body does, here's figure B here, looking at osmolality in the time frame here. The moment this cell, the hypothalamus sense an increase in osmolality, the ADH will be released, and as you can see here, the urine osmolality will be high, will going up accordingly with this. And if it will keep doing that until it can't do anymore, outpaced by the loss of water, then the plasma osmo will increase along with it. And by the end, it will continue to do that until the osmolality in the plasma drop before it will stop doing that. So sometimes if we test these patients, even after their hypernatremia resolved, we can still see high urine osmo. Same thing with the brain, except it has limited space. And so in acute hypernatremia can cause brain cell shrinkage. Same mechanism as before, and within hours it can accumulate some electrolytes to help, but the permanent solution or the long-term solution is the osmolytes, the organic osmolytes, which would take days or about 48 hours. This is important because when we manage hypernatremia, we separate it in acute versus chronic, which is greater than 48 hours. So it affects hypernatremia affects all cells, but it affects the brain cells mainly because the brain has limited space, or the skull has limited space. Anorexia, restlessness, can go nausea and vomiting. These are early, and later on patient can develop autonomic status, and all the way to ataxia and tremor, and stupor and coma. Focal deficit like hemophilia has been reported. Again, as we gone over earlier, hypernatremia, we look at sodium, and then you look at the urine osmo. If the urine osmo is high, then kidney is doing its job, then it's look for the cause somewhere else. If the kidney is not doing its job, which is the urine, when the osmo is less than 700, this is the cutoff for then we need to look further. If the urine osmolality is really low, and you have a low solute or low urine sodium, then it's likely it could be from water diuresis, aka diabetes insipidus. And here on this opposite end, if we have a somewhat less than 700, but somewhere between 300 to 700, with a high solute contents, then it's likely from diuresis. So case 3. We have a 79-year-old woman, nursing home residents with past history of hypertension and CVA, admitted for decreased mental status for over 5 days. On evaluation, she was somnolent, temperature of 39.5. Blood pressure is normal. Pulse is 102, respiratory rate 24. Weight 56. She has reduced breath sounds. Chest X-ray shows left lobar pneumonia. Laboratory is significant for serum sodium of 170 and K of 4. Creatinine is 1.5 and urine osmolality is 780 milliosm per kilo. She was given 1 liter of saline bolus in route. What would be the repeat sodium level in this patient after a liter? Any taker? Is it A, B, A? Is it increase, same, decrease, decrease a lot, or decrease a lot? It's increase or the same? The same? Okay. All right. It looks like the answer is B, the same, almost the same. And we can go over calculation shortly. So just shortly, just to evaluate this patient and looking at her, so we generally evaluate by looking at the whole picture, the history. She has ultimate status or CVA history. Unlikely she can provide her own water, and so decrease water access, decrease thirst, and she's also hypovolemic. She's also she was febrile as well. Next, we look at labs. She is hypernatremic, and again, hypernatremic is always associated with hypertonicity. Next, we look at the urine osmol. This patient urine osmol was 780. Again, if we look at 2 slides before, any urine osmol greater than 700 is likely more consistent with the kidneys is working, but there's problem with free water intake. Okay, and so the diagnosis is hypernatremia from low intake of and high loss of free water with an appropriate renal response. And management. Okay, so we do number 1 thing we do is address the underlying cause. 2 is correct the prevailing hyperosmolality. The problem is if we're correcting too fast, we develop cerebral edema. If we do it too slow, as we know, we looked at it before, there's increased mortality. We corrected too slow. Here's the another study, retrospective again. Sodium of 131, sample 131. And they compare hospitalized versus hospitalized patients with hypernatremia of 155. They correct them. They divide them into 2 groups: fast versus slow, and the rate is the cutoff is 0.25. And we can look at the Kaplan-Meier curve here, and we can see that the correction rate greater than faster, greater than 0.25 has better mortality benefits. And they all on the right here, they looked at the non-survival cases, and their sodium level was corrected a lot slower, difference of about 5 to 7
milliequivalent here. Recently, another study came out, just another retrospective chart review. They look at sodium level hyponatremia on admission and sodium hyponatremia in hospital acquired. The cutoff is 145, and they correct these patients in rapid versus slow, and their definite their goal is either less than 0.5 or more than 0.5, and they compare the mortality between in the two groups. The group that had community acquired versus hospital acquired hyponatremia, they did not find mortality difference in either slow versus fast in either of those groups. Significant finding is that 0 cases of cerebral edema was found. So they conclude that rapid correction might not be so bad after all. However, this is again a retrospective study. And this is the just to show between the two groups, and red is the rapid correction group and mortality. Only this is significantly statistically significant. Okay, so onset. We look at hyponatremia management. Less than 48 hours is considered acute and plus symptomatic. And in this case, we should correct it faster, 2 to 3 millimole an hour, but max within like 12 millimole per day. For chronic, we do it a little slower. We can do up to 10 a day. But again, after the studies what the study found, this recommendation was in 2013, and the study recent study was in 2019. So we can potentially correct it a little faster. If volume status, if hypovolemic, we can give isotonic solutions, and then switch to D5 after. If they euvolemic, we can give 5% and loop diuretics, and if they hypovolemic, we can just give the same 5% and loop. So these are the formulas that we mainly use to calculate sodium level, and it helps the elementary equation, as we talked already before, Andrew-Madius formula. This is very useful if we want to calculate how much sodium change if we introduce 1 liter of any type of solution. And then equation number 3, we're looking at total body water deficits. So current sodium minus target sodium over the target sodium times the total body weight. Okay, so looking at case 3 earlier, and so we what happened after we gave 1 liter of normal saline, which has 154 milliequivalent of sodium? We take using this is one way to do it. We're using equation 1, Edmonds equations. Total body sodium over total body water. We have, and then we switch that around. Since the serum sodium level was 170, we multiply that by the total body water. Then we get the total amount of salts. And then after the total body water, new total body water, or the current total body water is 28 here. Now, after we give 1 liter, we take the total body salts plus 154 in a liter. We get that, and the new total body water is 129, and divided we get 169. Hence the sodium was somewhat similar after 1 liter of normal saline. What about after 1 liter of LR, or using looking up top here, we're using a different equation, the second equation, where we take the infusate sodium minus the serum sodium divided by the total body water plus 1. So we can get similar finding here, 169.4, or it changes by 0.5. What about LR? After 1 liter of LR, again, similar calculations, which gives us about, it changes about 1.4 milliequivalents. So this is to emphasize that, one, if we give isotonic or if we give normal saline with LR, it will unlikely to correct the hypernatremia. And so in the case of patient that needs resuscitations, we can be liberal with our fluids, in our isotonic fluids. Okay. So the repeat sodium after was 169. How much free water needed to correct this patient's to 157, which is about 12 at 24 hours. So A, B, C, D, or E. So after going through the calculations, I think if everyone agree with me that A and B would not be the right answer. Stir water is not the right answer neither. And so it leaves us C and D. Any taker? D? Is that what I heard? Okay. All right. Yeah, it would be D. So similar things, calculation, just current sodium minus target sodium over target. 169 minus 157 over 157. Multiply with total body water. And we get 2.2. And don't forget to calculate the insensible loss. Then we get a total of 3,040 milliliter, which is divided by 24, you get 125 B5. So note these estimates are only help as starting points. We do have to monitor the sodium and go up or down based on the patient's response, because they could have ongoing GI loss as well. And I think, okay, one more case and we'll be done. 43-year-old woman with advanced amytrophic lateral sclerosis, ALS, maintaining on home ventilator, admitted after being found unresponsive, requiring CPR for multiple cardiac arrests. ROSCochieved after 50 minutes. Patient have just recurrent arrest. So she received about 10 amps of sodium bicarb during resuscitation. She was also in septic shock from pneumonia. She received IV fluids and antibiotics and vasopressor. She weighs about 50 kilo. Post-cold labs, sodium 150. 24 hours prior, she was 135. So potassium 4, WBC 30,000, 37,000. Creatinine is 0.2. CT head consistent with hypoxic, ischemic brain injury, and early signs of cerebral edema. What is the likely cause of her hypernatremia? A? D? Okay. Yeah, D is correct. And case 4, looking at the diagnosis here, looks like hypernatremia from hypertonic solution, sodium gain during CPR. 10 amps of sodium bicarb, each amp contained about 50 milliequivalent of sodium and bicarb. And if you get 10 of that, it's about 500 milliequivalents. And just as a reference, 3% sodium, a liter of 3% sodium, 3% hypertonic solution, it has about 513 milliequivalents. So she technically received almost a liter of 3%. So that's why it went up pretty fast. So let's say hypothetically, if let's just say the patient's sodium was only 135, we didn't give that 10 of bicarb, and we need to bring up the sodium because of the cerebral edema. How do we get there? And we can use this same equations. to estimate as well. The change, 513 down here is the 3% minus the serum sodium and divided by the total body water plus 1 liter. And we can see that it will change about 14 million equivalents after 1 liter of 3%. And that will help us bring the patient up. And I think we'll conclude it here. So I just want to go over the summary here. Hypernatremia in ICU associated with increased length of stay and mortality. And but these are all based on prior retrospective studies. It is associated with hyperosmolality states. It is well known, hyperosmolality state is well known to have adverse effect on the cell functions. The rate of corrections, again, most of them in the past was based on pediatric populations, and they used it was pediatric patient with gastroenteritis, and they give them free water and the sodium corrected, and they see between the group to see if there's evidence of seizure or not. And so that might not be very relevant to our population, adult populations. And then plus based on the new studies, we can potentially be a little more aggressive with correcting these hypernatremia. The study that was done in 2019, they corrected up to 14 equivalent per liter per 24 hours. And the last point is the equations are meant to provide an estimate of the correction, and so it's just meant to help guide us to how much to start with, and as a starting point, we do need to monitor the sodium frequently. And these are my references, and thank you for listening. Any questions I can answer? All right, that's it. Thank you.
Yeah, let me pause this first so I can stop recording.